Thank you very much, sir.
Welcome, sir. Dr. Jagdish Chinnappa. So, sir will be talking about ethical issues in pediatric pulmonology.
Thank you, ma'am. Thank you so much. Good afternoon, everybody. And when I was asked to speak about this topic about 10 days back, I was wondering that this is a very unusual topic for a pulmonology conference. So then I asked the organizers why this topic was chosen. And it was very interestingly said that this is mandatory according to the medical council, that the conferences should have at least one topic on ethics. So this is a mandatory topic. So anyway, what I'm going to talk about in the next 15 to 20 minutes, basically I know all of you all will be very familiar with the fundamentals of pediatric bioethics, but I thought we'll make it interactive. So if I can request those who are at the back to please come in front, we can have a good interaction in the next 20 minutes. So the core principles of ethics as enunciated by Beauchamp and Childress are autonomy, beneficence, non-maleficence, and justice. These are the broad outlines of ethics in pediatrics. The first three are relevant primarily to individual health, whereas justice is also relevant to individual health and public health. If you expand this a little further, the core ethical principles can be expanded to a number of other things, like, for example, what is the best interest standard, who are the co-fiduciaries, how veracity is important in pediatrics, professionalism, communication, shared decision-making, consent, assent, confidentiality, the harm principle, equipoise, competency. So when you're dealing with patients, any one of these or a number of these will come to play in a case, in a given case. So let's start with this scenario number one. How this is going to be shown is, first I'm going to project the case, next the choices, third how we will resolve it, and finally which ethical principles are brought forth. So I will start with the first situation. 14-year-old Sarah with severe exacerbations of pulmonary symptoms of cystic fibrosis and hypoxemia refuses IV insertion of antibiotics. This is a very common issue when the 14-year-old has had repeated hospitalizations and treatment. The father insists on putting the IV line. What are the choices we have? Can we insert the IV line despite her protests? Can we refrain from inserting the IV line? She is hypoxic and therefore we consider her incapable of making a considered decision. Take her mother's opinion or get a legal opinion. So, inside of protest. Okay, that's one opinion. Madam? Ma'am, you can sit down. No. Correct. Excellent, excellent, excellent. So, I think the important thing here is to involve persons closest to Sarah, explore the reasons for her dissent, why she doesn't want it, ensure a pain-free insertion, talk to her saying that it is not going to pain her, suggest if for a PICC line for future, start appropriate antibiotics, do non-parenteral routes immediately, and collect samples for culture. So this would be an important thing, and as Madam mentioned, assent in a 14-year-old is as important as consent, and you need to give importance to this girl's decision-making capabilities. She's a mature minor, and always a shared decision-making is important when you're dealing with a patient. Absolute empathy should be there, and always the best interest of the child should be taken care of. We know very well that the mental capacity of children develops with age, and usually by the time they're 8 or 9 years, they are capable of giving what is called as an oral assent. And once they reach the age of 12 years, they can even give a written assent. This, of course, is for research purposes, but you can use it otherwise also. So this is the scenario number one. I'll go to scenario number two. Now, Sarah is started on IV antibiotics, ceftazidime and amikacin. The sputum culture comes back and shows Pseudomonas sensitive to peptase, meropenem, levofloxacin, amikacin, tobramycin, and cefepime. Now, are there any ethical principles in choosing an antibiotic? As simple as that. Would there be any ethical principles involved here? Yes, of course, because as was spoken in the other hall during the cystic fibrosis, the first thing you do is do no harm. Look at beneficence, look at justice, look at cost, patient preference, and aware is the WHO acronym for antibiotic usage in the community. And the important thing here is divide antibiotics into 3 groups. One which can be freely used, one with restricted use, and the last one is to be used only under very special circumstances. So if you look at this group here, meropenem is a drug which doesn't work very well in pulmonary infections, and therefore that's straight away out. Levofloxacin is not a very safe drug, and therefore that also is not the first line of preference. Tobramycin nebulization is a good choice. Amikacin, unfortunately, is not available as nebulization. Cefepime is a reserve antibiotic. So, if you look at it ethically, the one that will benefit her best would be a combination of piperacillin tazobactam with a tobramycin nebulization. Okay? One that is least likely to cause harm and provide benefit. So, this child was started on piptaz and tobramycin nebulization, and till she was out of her problem, that she went out of her severe condition. And then she was continued on oral levofloxacin with tobramycin nebulization. She responded well, and the sputum became negligible after 4 weeks. And therefore, the important things which has been come out from this kind of a situation is, one, antibiotic stewardship is as important. So justice principles are important here. Multidisciplinary approaches required, and constant communication and proactive decision making is important. So even a simple act of prescribing an antibiotic has got its ethical principles, where you need to look at beneficence versus non-maleficence, harm versus benefit. So these are things that need to be looked upon. Now coming to the scenario number 3, we have V Pharma in the US has developed a new drug for cystic fibrosis. They want to include SARA in the trial. You are requested to be the principal investigator. They submit all the relevant documents for the trial. So what are the choices you have here? You immediately accept, you refuse because of conflict of interest, or you request time to study the issue further. Okay, what would you like to study further? No, that's already been submitted to the IEC. It's come to you as the PI. What do you want to do? Yeah, so I think the important thing here is, madam, would you like to comment? Yeah, yeah. Yeah, I think madam has brought it out correctly. I think 3 things are important here. One is, have you undergone any training to conduct this trial? So first thing, are you GCP certified? So that is extremely important. If you're not GCP certified, you cannot accept this straight away. That is point number 1. Point number 2 is, you need to study the documents to see what is the efficacy, at what stage of the trial this drug is being given to you. That means, has this drug undergone significant trials in other institutions or other countries where it has shown to be safe and without side effects, and has shown to be beneficial. So this is the 2 things that you need to look at. Third thing is, most of the institutions will have a scientific committee which will decide whether this trial is worth taking or not. And finally, it will come to the ethics committee. When it comes to the ethics committee, there is, of course, you'll have to register this with the CTRI and HSMC if you want to do this trial. But the important thing is, you need to define, is there any harm? Is there any benefit? You need to see voluntariness. Therefore, you need to look at informed consent and assent. You'll also have to consider whether there is going to be compensation for this trial, both in terms of insurance if there is a problem, how you're going to maintain confidentiality and store the records. Then, of course, I mentioned about the GCP certification. You also will have to look at multicentric, whether this is a multicentric trial or whether it's going to be at a single center. Why is it important? Because the ICMR has got now guidelines for multicentric trials. They are entirely separate from what you would do in a single center. then institutional approval, and finally, what are you going to do with the results? If you are going to publish, who is going to be the person in charge of publication and how many people are involved? What is your study team? So all those questions will come in. There is a checklist almost of about 50 items that you need to fill in before you start looking at whether you can accept this trial or not. Okay. Now, the next scenario is very common. Sarah does well on the trial drug. Her FEV1 improves quite significantly. Trial is over. The company has not got the license to market the drug. The drug costs about 1 crore per year, which the parents cannot afford. So what are your choices here? Continue routine care, explore insurance, crowdfunding, write to the company to provide the drug on compassionate grounds, petition the government, seek help from ORDI. Yeah, so sir says all of them. Yes, agreed, absolutely. So you need to definitely continue care and you can explore any one of these options. All of them are acceptable. So the Sarah was provided the medication on compassionate grounds, but in addition to that, she has joined the ORDI. ORDI stands for Organization for Rare Disease in India, who work basically, in fact, the 50 lakhs which is given to rare disease, for which CF is also one of them, was initially petitioned by ORDI, and subsequently the government sanctioned this amount, and now she has formed a support group to help other parents who can provide assistance to their children. So therefore, the important as far as ethical principles is, advocacy is as important as in public health ethics. You need to assume responsibility and you need to help patients move from fear to courage. Now coming to the next scenario. Now Sarah has grown up, she's now 18 years old. She comes to you with progressive loss of lung function. Her FEV1 is 25%, she's on optimal treatment. Now, what do you do here? Do you offer palliative care and say, okay, you continue with that care, or you look at the possibility of a lung transplant and say, okay, I'll review in 3 months' time? What would you do here? She's worsening. Her FEV1 is going down quite significantly. Okay, you can explore the possibility of lung transplant while continuing the usual care with whatever you're doing. So again, here important is to get joint consultation, continue care, and explore the option of lung transplant. Unfortunately, not many centers are doing lung transplant in India, so you need to look at who can do the lung transplant. So the important ethical principle here is how you're going to describe, or when you're going to look at futility. Ethics of transplant is a different legal aspects, and ethics of transplant is a very, very complex subject. I'm not going to get into it. But very important thing is to communicate the risks, benefits, and consequences. Because many parents think that if they do the transplant, the patient is going to recover and go about the normal duties. But that doesn't happen. There's a huge number of medical complications and long-term medications that is required. The last scenario is, while on the wait list for transplant, Sarah has had a severe bout of hemoptysis. She's brought in an unresponsive state and is put on the ventilator. Father insists on all possible treatment, including ECMO and accelerated lung transplant. He said, go ahead and do the lung transplant in an immediate pattern. Now the unit is hard-pressed for a ventilator bed, cannot discontinue care. Should they stop feeding the child? Can you stop feeding the child? No. Well, anybody says yes? Can you stop IV fluids and can you stop feeding the child? You can. Because once a patient has been declared brain dead, you are not prolonging living at all, you are prolonging dying. No, she's unresponsive state, she is brain dead only. Okay, I'm sorry, okay, fine. Yeah, you have to certify brain dead, but she's brain dead. Okay, so in that situation, basically you can stop feeding the child. So this is a constant dialogue because yes, this is a very difficult situation for the parents. Sometimes we have to look at prolonging life or prolonging death. What are we doing? And non-escalation of care and organ donation may be other things that could be decided. So here, the ethical principles are basically end-of-life care, legal issues, and family interests. So basically, when we are going through various types of clinical cases, ethical choices are prevalent in every encounter. Every encounter that you have with a patient will have some ethical issue. Encounters can be in 3 basic groups. They can be either clinical areas, research areas, or public policy areas. In if you are looking at clinical ethics, the main thing that you need to look at is beneficence, or what is going to help the patient recover from whatever he has. In research, you have always to be looking at what is the harm that can happen from the research. Autonomy is an important concept even in adolescents. And we often forget about justice because that is for the public good. So we always need to keep the public good in mind even when you're treating private patients. Thank you very much. Thank you.
I have two questions regarding assent and consent.
Yes.
Actually, I am working in adolescent field and child development. So there is issue regarding, the developmental age of the child, isn't it?
Yes.
So if age is around 14 years, but developmental age is not matching with chronological age, then there will be issue, isn't it? Intellectual disability and all this.
Correct.
thing.
So if you are absolutely right, madam. So that is the concept of the mature minor. So it is up to the practitioner to understand whether the patient understands the consequences of giving permission. For example, now if you have a child, let's say you have a Down syndrome child at, let us say, 14 years old, who is unable to comprehend, whose functioning capacity is, let us say, 7 years or 6 years or 7 years. That child is not a mature minor. That child right now continues to be a child who's got challenges. So therefore, is incapable or is not capable of giving consent.
Any legal issues like aged autism child, 17 years.
Yes.
So give consent, assent or not?
No, assent is, see, that's what I'm saying. It is all on an individual basis. For example, even in autism, there are high functioning autistics whose intellectual capacity is very good.
That's why I
So the issue is that it all goes case by case.
Yes.
So it is up to you to say, yes, this child has got capacity to consent or not, assent or not.
Yes, sir. And some major issues where they cannot give and we have to inform the caregiver, na?
Yes. For example, yes, absolutely. So there, for example, now you cannot do anything to a child without parental consent till 18 years of age.
Yes.
Okay. But when you are taking that, some adolescent who comes to you, let us say at 16 years and says that I have ideation to kill my friend because of whatever reason. Now this has to be reported because this is going to harm somebody else. Okay. At the same thing like what you mentioned, suicidal ideation, that has to be reported because there is a likelihood of harm. Yes, Dr. Ali.
Hi, there's a lot of learning, Dr. Jagdish. Now, we come across these common situations where of declaration of death and where we face the situation of declaration of death where there may be a lot of possible violence and all. So till then, continuing treatment till you have prepared everything and all, is it right or wrong, in spite of the patient being dead?
I think the important thing here is that you have to safeguard yourself from such eventualities of violence, etc. But you cannot postpone the declaration of death. That is not right.
Yeah, continuing the treatment in spite of the patient being dead because
that is wrong.
You're preparing for the situation, a proper situation to declare death so that you do not be harmed by the patient's attenders. And because it's very common in those places.
If you ask me,
To
Doctor,
prevent violence.
you ask me if we are in what is called as a gray area. Okay, so let's leave it at the gray area because every situation may be different. If you are a solo practitioner with no protection and you have a huge number of people, obviously you will wait for somebody to come before you declare. Because protecting yourself is as important as protecting the ethics and legality of the death. So I think the point is these are things which are on an individual basis you need to take a decision. You can't take a blanket decision.
Thank you, sir.
Thank you.
For interesting and interactive session. Thank you so much.